cutting edge webinar series, which is the brainchild of Dr. Meenu Agarwal Madam. We've been successfully conducting these webinars every Tuesday evening with different societies of obstetrics and gynecology. And today we are delighted to be having it with the Delhi Society. So I request Charu ma'am to just welcome the dignitaries and we can begin.
Good afternoon, everybody. Indeed, a pleasure to see each and every one of you. We are so blessed to have such eminent chief guests of honor, and such eminent faculty for today's webinar. The cutting edge webinar, as Dr. Madhura just mentioned, is on important topics regarding laparoscopy, ovulation induction, and of course, intrapartum care, which will benefit each and everybody. I welcome Dr. Sunita Tandulwadkar, our chief guest for today, Dr. Neerja Bhatla, and Dr. Niranjan Chavan, who are our guests of honor, and of course, Dr. Ashok Kumar, Dr. Nidhi Khera, and Dr. Indu Chawla, Dr. Kamna Datta are here. So a warm welcome to each and every one of you. Of course, Team POGS is always together. All of them are here. So it is a pleasure to interact with the Delhi OBGYN Society for this particular webinar. Can we play the prayer, please, for a formal inauguration of the webinar? Welcome, Dr.
Kurutvang kalyanam arogyam dhanasampadah Shubham kurutvang kalyanam arogyam dhanasampadah Shatrubuddhi vinashaya Deepajyotirnamostute Deepajyotirnamostute Shubham kurutvang kalyanam arogyam dhanasampadah Shubham Kurutvam Kalyanam Arogyam Dhanasampadah.
Thank you very much. Over to you, Dr. Vaishali, to inaugurate, to introduce our chief guest.
Thank you, Dr. Charu, and it is a great honor and a great privilege for me to introduce today's chief guest, Dr. Sunita Tandulwadkar, President-elect FOGSI, and she's entire Pune is proud of Madam. Not only Pune, the entire India is awed with Madam's dynamism, and she's completely unstoppable, and she is one and only Dr. Sunita Tandulwadkar. She believes in the best. She believes in passion, perseverance, and dedication to her craft. The one who loses herself in finding others. She is one who is draped in confidence, setting benchmarks as she travels a road of success, and she's simply unstoppable. She believes she can, therefore she did, and she wears a crown of passion. And now she is the President-elect FOGSI. She wears that crown so well. And under her able leadership, she brings out the best in all in workplaces and organizations. She's an experienced veteran, skilled endoscopic surgeon, a ray of hope for millions of childless couples, a pioneer in stem cells, and a teacher par excellence. Dr. Sunita has played a role model for many young achievers in the making, and her organizational skills and perseverance to serve the society has brought her to the helm of various prestigious organizations. Like right now, she's President FOGSI-elect, she's ISAR President-elect, and she's also founder president Society of Ovarian Regeneration. She's past president of IAG, past president of Pune OBGYN Society. So she has been leading so many organizations, maybe the only person in India who has been president of so many organizations. She's past chairperson Maharashtra chapter ISAR, elected board member of ISG, Indian representative to Aspire, endoscopy committee member, AOFOG, invited faculty for ASRM.
Vaishali, thank you.
Madam, a lot of things are left.
Let's have academics going more than our introduction. So first of all, thank you so much, POGS and AOGD, for having me here. I could see Dr. Aarti Nimkar, who has recently taken over as a POGS President Secretary Dr. Meenakshi Deshpande, and the brainchild of this cutting edge, Dr. Meenu Agarwal, Vaishali Chavan, her secretary, and Charu Bape. They just finished their absolutely fantabulous tenure as a POGS team, and it's always pleasure to be with AOGD. AOGD is close to my heart, and we need to congratulate Dr. Ashok Kumar, who has taken up the president. AOGD has given Nirja as a vice president. Thank you, Nidhi ji, and entire team of AOGD for having me with you. Nirja, I always, you and Ashok, I have no words to express my thanks for your such a huge support. AOGD plays a very crucial role in my elections, and you were very strongly supporting. I'm thankful to you. Induji, I have not forgotten you. Thank you so much. And entire, AOGD being such a large organization, your east, west, south, north, all those areas, everyone is, so academically ahead. I don't know how many meetings you do every week, and so much of a sharing of a knowledge in each and every program. Similarly, is a POGS coming always out of the box ideas. I think, Minu, this program which you have created, absolutely fantabulous. I feel sometimes webinar are so many in gynecology, OBGYN, people, our friends at Ruby Hall, whether they are orthopedician, general surgeons, onco surgeon, they laugh at us. क्या रात दिन conferences करते हो, meetings करते हो, कितने webinars करते हो? We have only 2 conferences in a year. The cardiologists also laugh at us. But what I feel is, every conference, every webinar you join, you at least carry home at least 1 or 2 important take-home messages which help you to grow in your practice, to widen your thinking. So it helps. I always tell, yeah, we need to, because we are 43,000 gynecologists. The organization is also so big, so that we do at different time, different program. So many cannot join, but few may join and they learn. The best of the faculty you have chosen, Minu, yourself, Dr. Ashok Kumar. It will be such a pleasure to listen to you all. And I wish you all the best for your all future endeavors. Thank you for having me with you all.
Thank you so much, Sunita. Your encouragement really, really means a lot to me and to us, all of us at POGS, because POGS is a very vibrant society, and POGS has given many precedents, many, big names in Foxy, ICOG. Now Parag is the ICOG chair, and of course you are there. All 3 societies, like organizations, like Vaishali said, you're there for ISAR, for IAGE, and for Foxy, presidentship of 3 big organization. It only shows that your skills in endoscopy, in ART, and also in high risk obstetrics. So all 3 are there for you to reach that level. So thank you very much for your blessings, and we look forward to your blessings always. Thank you.
Thank you, dear. Thank you. Thank you. Wish you all the best.
Thank you so much. Thank you.
Now I
With that-
request. Yes, ma'am.
So-
Charu, ma'am.
Yes, indeed. So, our guests of honor today are none other than Dr. Nirja Bhatla, ma'am. She is our beloved Vice President Foxy currently, and I think that she has made a name not only for herself, but for India, as she has, changed the configuration of CA cervix, the entire staging of CA cervix, and that is such a big thing that she has done for the entire world, where she has staged carcinoma cervix, and just to show her in-depth knowledge of this particular topic and her dedication to the particular cause of eradication of cervical cancer from the surface of this earth. Dr. Nirja Bhatla, ma'am, has been working in collaboration with WHO, Johns Hopkins Bloomberg School of Public Health, and is the recipient of a UICC ICRETT fellowship, which I won't really understand too much about. But we have an extremely learned person with us today. She's a professor at the All India Institute of Medical Sciences. And indeed, we have one of the greatest academicians today as our guests of honor. So over to you, Dr. Neerja ma'am, to kindly say a few words for our webinar and to guide us further.
Thank you, dear Charu, for that kind introduction. And thank you, Dr. Meenu, for inviting me here. And it's so wonderful to see all the people that one, really appreciates the way they work and all. And Dr. Vaishali, Charu, all of them have been consistently working. This Cutting Edge is such a beautiful program. And I am delighted to see also Dr. Aarti. Congratulations, Dr. Aarti, and wish you a very scintillating tenure, Dr. Aapki team also. And of course,
Thank you,
my
ma'am.
Society, and it is so wonderful to have them here in partnership with you today. And a lot of words of wisdom from Dr. Sunita, who is one of my very dear friend, really. So it's always a pleasure to see. And what a beautiful introduction you gave. You just couldn't have said it better. Her dynamism, her confidence, her charm. Oh, wow, you said it all. And her academics is always in the forefront too. So we've been having so many webinars, rightly said, and Dr. Madhuri and our entire team of VPs, we are constantly trying to engage with the audiences on this. I'm really happy to see your Cutting Edge, because this infertility is such a problem for women everywhere, I'm sure, but especially in India, where it makes the difference between her social position to have this label of infertility and voluntarily not to have a child is almost never. So there was a time when I used to say that giving a diagnosis of infertility to a woman is as bad as giving a diagnosis of cancer. Their reactions are pretty much the same. But now I'm so happy to see that within a couple of decades, how many strides we have made, that we have so much to offer to these women, and with can walk into an ART center and hope to come out with a take-home baby. So it's a wonderful selection of topics. We have great speakers, and I'm looking forward to attending as much as I can, because there's another one coming up, NCD webinar, so I may have to leave in a little while. But congratulations for your effort, and thank you for having me here.
Thank you, Dr. Neerja madam, for the kind words. And we are meeting very often on this Zoom virtual platform, and I hope to meet you in person soon, sometimes, for sure.
Definitely, definitely.
Yes, I think Calcutta we will
You will be meeting her in Calcutta. She is teaching BP. Neerja has no choice than to be in Calcutta. And we know you also don't have a choice than to be in Calcutta. So Calcutta is the place where we all meet.
Absolutely.
Yes, indeed. So thank you so much for your nice blessings and nice talk about, yes, infertility, though we are keeping the topics more of a mixed bag. But infertility is the prime topic that we try to keep every Cutting Edge webinar. And like you said, the right to have education, the right to have food, the right to have a house, the right to have a child. Again, it is the right which we need to, as far as possible, provide to the lady who's not able, or the couple who are not able to conceive. So thank you so much for the kind words. Thank you very much, Dr.
Thank you, Dr. Neerja. I think that Dr. Niranjan Chavan has not been able to join. May I request Dr. Ashok Kumar sir to kindly say a few words?
Who is introducing Dr. Ashok?
Supposed to introduce Dr. Ashok
Yeah,
Kumar.
please introduce first.
Has he joined?
Dr. Ashok Kumar sir, are you there?
Yes,
Yes, I am there. I am there.
Madhura, please.
Yes, ma'am. So, ma'am, Niranjan Chavan sir is not there. So, sir, I think we'll directly begin the first session.
I think, yeah, but we will just introduce Dr. Ashok Kumar sir and have
Yes.
his blessings also, because, it is so difficult to catch Dr. Ashok Kumar sir. He's so busy. He's the director, professor, and head department.
Charu Pape, can I introduce him because it is there?
Oh, please. I'm sorry, Meenakshi. I'm sorry. Please go ahead.
Sure. Yeah. And can you put my introduction slide, please?
Yeah, it is there,
That
Meenakshi.
is there. That is not being put last time.
Yeah,
also.
it is there. I can see the introduction slide.
Yeah. Can you put it for 1 minute, please?
Yeah, it is there, Meenakshi.
She wants her introduction
It is
slide.
not there here. It is not seen on the screen like.
I can see it. Maybe you
Ma'am, you
change.
want
She wants
yours?
her introduction slide.
Yeah, first let me introduce myself, then I'll introduce Dr. Ashok Kumar, right?
Yes, please. Yes, please.
Thank you so much. Yeah, I'm the Secretary General presently of POGS. So welcome you all to this most important and wonderful cutting edge webinar, which has been brought into our POGS forum by Dr. Meenu Agarwal. And I'm a practicing gynecologist. I usually practice high risk pregnancy, and I'm also a medical legal person doing my LLB. So thank you. I will now like to introduce Dr. Ashok Kumar. Welcome Dr. Ashok Kumar to this webinar. And I find him the right person for me to introduce because I see him as a special interest in maternal health. Mostly many people put special interest in infertility, endoscopy, but I like it, Dr. Ashok Kumar, that you have put it as a special interest in maternal health. He is the director and professor and head of Department of Obstetrics and Gynecology of Atal Bihari Vajpayee Institute of Medical Sciences and Ram Manohar Lohia Hospital, New Delhi. He is the vice chair elect of ICOG 2024 and secretary of ICOG. He was a secretary of ICOG 2021-23 and he is the president of Delhi Society of AOG 2024-25. He's done his MD from New Delhi and his PhD from the Tokyo Women's Medical University. He's the editorial member of Indian Journal of Medical Research, Archives of Gynecology and Obstetrics, and of course, like I mentioned before, special interest in maternal health. He's also received a Dr. Satya Paul Award of 2019 for excellence in high-risk pregnancy management. So I welcome Dr. Ashok Kumar on this POGS forum and webinar of Cutting Edge. Welcome you again, and you can request it to. Yeah, thank you so much.
Thank you, Dr. Meenakshi. First of all, Dr. Aarti, President of Pune Obs and Gynae Society, Dr. Meenakshi Deshpande, General Secretary, Dr. Meenu Agarwal, immediate past President of Pune Obs and Gynae Society, Dr. Charulata, Chairperson for Study on Female Breast Committee of FOGSI, and Dr. Vaishali Chauhan, past Chairperson Perinatology Committee of FOGSI. It is indeed our pleasure from AOGD side to be associated with you for this cutting edge webinar. And we are thankful to our chief guest, Dr. Sunita Tendulkarkar, Dr. Neerja Bhatla. Dr. Niranjan Chauhan is not here today. This cutting edge webinar, I hope, is a series which is going on for a long time. And I hope all our participants and reader will be benefited from this. And we are wishing Dr. Meenu Agarwal also for success in her all future endeavors. And AOGD feels proud to be associated with this webinar. And I have with me Dr. Indu Chawla, who is the Vice President, and Secretary Dr. Kamna Datta with us, and many other participants from AOGD Society. So I hope this program will be successful, and wishing you all the best, Dr. Meenu Agarwal, and all the office bearers and the members of Pune Obs and Gynae Society. I have a close association with Pune Obs and Gynae Society. I have been to Pune for multiple times, and my best friend, Dr. Parag, is already there in Pune, and Dr. Hemant Deshpande is also there from D.Y. Patil Medical College. So I have visited Pune many times. I have a close association with Pune. Thank you very much.
Thank you, Ashok sir, and congratulations for taking over the presidentship of AOGD. It's a very huge, humongous task, and I'm sure that you will take it and you will carry it with huge grace and Eleanor. So all the best, and I'm sure your program must be all planned. And Delhi, as Dr. Sunita said, is a very big society, very enthusiastic. East, west, north, south, everybody is there in Delhi. So Delhi is like the center of gravity for all of us. So thank you very much for joining with POGS Society today for this cutting edge webinar. Thank you, Ashok sir.
Thank you, sir. I would like to invite our next chairperson for the session, who's Dr. Indu Chawla. She is the Vice President of AOGD. Can we have a slide? She's been practicing since over 30 years. She's been a professor and consultant at various hospitals in Delhi, like ABVIMS and RML Hospital. She was the executive committee member of NARCHI. She was the executive committee member of IAG Delhi chapter. She's a member of endoscopy committee, endometriosis committee, and she's been an executive committee member of AOGD. She has special interest in gynec endoscopy, and also madam has several national and international publications to her credit. So I welcome you, ma'am, and request you to say a few words.
Okay. You are muted.
So, yeah. Thanks for the nice introduction. Good evening, Dr. Sunita, Dr. Nirja, and all esteemed colleagues from Pune Society and AOGD. I really feel privileged and honored to be associated with Pune Society, and we are doing this webinar in collaboration with you, and hope to do it more in the future. And I really like the topic cutting edge, and thanks for the webinar. I mean, conducting the webinar with us, and I wish you all the best for this webinar. I think we'll go on to the webinar. Thank you.
Thank you, Induji, for the kind words. And we surely will do more with AOGD because see, knowledge exchange can be unlimited. So
Yes.
it's effective. So, and cutting edge, we named it because we wanted to take all recent topics and recent guidelines on various pathologies. So that was the idea. And thank you for liking the name of the webinar.
Thanks for clarifying. I was wondering why you have kept the name cutting edge. So I like the name.
Thank you. Thank you.
Indu ma'am, I would like you to introduce Dr. Meenu Agarwal ma'am in short, so that we can start with her talk.
In 2 lines, so we can start with the lectures.
So my CV is being displayed. So can I have Dr. Meenu?
इंदु जी अब 2 ही लाइन में करिए बस, है ना?
I know madam has been immediate past president of Pune Ops and Gynae Society. She is very active and she's done a lot of work in endoscopic surgery and infertility. And she'll be elaborating on ultrasound in gynae, especially in infertility. So very important topic. Over to you, Dr. Meenu.
Thank you. Thank you so much, Dr. Induji. And I will share my screen now. Okay.
Dr. Meenu, while you are sharing your screen, I would just like to add that Dr. Meenu, we seek everybody's support for Dr. Meenu's candidature for Vice President Foxy West Zone. And as you can hear when she will present a talk, she is really an expert not only in endoscopy, in ART, in imaging, and all the topics. And she takes training classes all over the world. So she is truly the most apt candidate for such a post. So all the
best, Dr. Meenu, all the best.
Thank you so much. Thank you, Nirja madam. Thank you. I am not able to share the screen. I don't know why. Okay. Yes, I can now. I can. All right. Okay. talk today is a very, very simple talk, ultrasound in gynecology. Okay, so I strongly feel that all of us obstetrician and gynecologists should be able to do basic ultrasound for the patient, or at least able to understand the report that we get. Sometimes we get a color Doppler report, 34 weeks pregnancy, this is how much is the fetal placental flow, this is how much is the umbilical, and we are not able to actually decide whether this patient should be delivered or we should wait. So we need to understand the basics of ultrasound, both in gynecology and in obstetrics. I was the imaging science chairperson, and my advocacy in my 3 years tenure, we conducted so many workshops in every, even small towns, that every gynecologist should be able to do a good pelvic ultrasound. This journey was difficult for us because I did my post graduation from AFMC 1990. We had only one ultrasound machine in the entire department, and that too because we were lucky to be in Armed Forces Medical College, and many colleges did not have. So, and we were not allowed to touch the ultrasound machine as residents. So it was a difficult journey for us. Now it is much easier for the because the access is there to the ultrasound machine. Patient is much more comfortable when she is doing the ultrasound with the gynecologist as compared to with the radiologist, especially when we want to do a transvaginal sonography. Time management is also much better. Patient is come to see us in the OPD. We can there and then do the ultrasound. We know the findings, we know the diagnosis, and we can immediately start the treatment rather than to and fro sending the patient to the radiologist. Now, whenever we are doing a routine ultrasound, first thing is to know what should be the normal size of the uterus. So, if you close your fist, simple, that is the normal size of the uterus. It is pear shaped, and this is how a normal size. So, if we can even judge from a normal size uterus to an abnormal size uterus, it is very bulky or it is very tiny. So both the things are very, very important, especially in cases of infertility. So you need to take a fundus to the cervix length, the depth, and in a coronal view we can take the width. So this is how the coronal view is, and there are a lot of, if you go through and read about, you can do MRIs, you can do 3D, 4D ultrasound, all of that. But even in a 2D ultrasound, you can very clearly at least suspect that it looks like a bicornate uterus, it looks like a septum there, and then you can get it confirmed either with a 3D, 4D ultrasound, or if you want to do an MRI. Looking at the endometrium again is very, very important. For a lot of people are managing infertility in the ART level 1 clinic where you're only doing IUI. And so those ultrasounds are again important, especially to see what is the thickness of the endometrium, whether we should go ahead for the IUI, or we should cancel this, or this patient needs a hysteroscopy. So all these things are important in terms of infertility management. Sometimes you find a thickened endometrial lining, you can see over here. So what in our OPD we do? We keep an IUI catheter. It is always there in the OPD. We just take little normal saline and push it transcervically into the endometrial cavity. And see here, you can see a beautiful polyp here floating in the fluid. So you have the diagnosis in hand. You can also put a color Doppler to see if at a single vessel supplying to it, and then you can plan the patient. Or if it is just an overall thickened endometrium, you know that you can give her a withdrawal bleeding, call her after post-menstrually, and maybe at that point of time she will have normal endometrium. When we look at the ovary, see, this should be the size. If you take your thumb and you go till the base of the thumb till here, so this is the normal size of the ovary, or is the bigger almond, the American almond, the big almond size ovary. So that should be the normal size of the ovary on ultrasound. Again, size of the ovary is important, because if the ovary is smaller in size, lesser number of follicles, you will probably suspect that she has a lower ovarian reserve, or if she has a very bulky ovaries, thick stroma, follicles arranged all around, then it could be a PCO ovary. So first to know the normal ovarian size, and then of course you can correlate whether the ovarian size is smaller in size or it is bulkier. Also, very important when we talk about polycystic ovary, sometimes we get these young girls with the very, very anxious mothers. Oh, my daughter has got a polycystic PCOD or PCOS. Now, it's as if but ESHRE guidelines, what do the ESHRE guidelines say? That polycystic ovarian morphology on ultrasound should only be diagnosed in girls more than 8 years of post-menarche. That means if she got her periods at the age of 11 till the age of 19, ultrasound should not be the primary criteria to diagnose. Of course, any symptoms of hyperandrogenism, she has weight gain, she has hirsutism, she has oligomenorrhea. So you can consider those, but ultrasound should not be the main one of the criterias unless she is 8 years post-menarche. And after 8 years more post-menarche, if the ovarian volume is more than 10, or she has at least 20 follicles per ovary, so that is the criteria. So this is how, and this is a polycystic ovary. So if we get a young girl with her mother with an ultrasound report, and if the ovary looks like this, here we can see this is I'm sorry. Okay. So if the ovary looks like this, see this portion, this is the stroma. And if the stroma is not, if the stroma is showing the follicles, that means this is not a polycystic. This is just a multifollicular ovary, because she is a young girl, she has a good ovarian reserve. And for polycystic ovary, very important to look at this part. So this part is the thickened stroma which is there. And this is again, sometimes in slim PCO patient, this is how the ovary, sorry again. So this is how the ovary may look. Again, very tiny follicle are seen. And so these patients, if you do their FSH, especially these very, very tiny follicles, they may be resistant to clomiphene, resistant to letrozole, and you may have to go for gonadotrophins in these cases. And then, of course, if the ovarian size is small and if the antral follicle count is also less, so that kind of will tell you whether this probably patient is of a poor ovarian reserve. Now, whenever we are doing an ultrasound, if we find any cyst with very low level echogenicity, like this ground glass echogenicity, it is very clear diagnosis of endometrioma. However, if you find an endometrioma, we should not stop at that. Look for, or send the patient to look for, if she has any problem in passing, pain during passing motion, severe pain at the time of intercourse, severe dysmenorrhea, we should also look for rectovaginal and nodule, because many of these patients with endometriomas may also have a recto. I mean, in the latest publication, they have shown 60 to 70% of the patients may have a deep infiltrating endometriosis along with the endometrioma. So that possibility should be kept in mind. So whenever we see an ovary, उसके अंदर छोटे छोटे balls हैं. So whenever you see this echogenic or mixed echogenicity balls in the ovary, so this is very, very typical of dermoid cyst. So but if a patient has come with infertility, you do the ultrasound, उसमें हमको लगता है it is a dermoid cyst or any adnexal mass, the focus should shift from infertility to dermoid or any adnexal mass, because that is first priority to make sure that we are not dealing with any kind of malignancy, and first look into that and then go for the infertility. Again, in adenomyosis, whenever we find one wall of the uterus thicker than the other wall, see here, one wall of the uterus thicker than the other wall, it is adenomyosis unless proved otherwise. You may also find small cystic areas, small echogenic areas that will also prove your diagnosis. So whenever we are doing an ultrasound, when we look at the iliac vessels, medial to the iliac vessels is the ovary. If you find any tubular structure between the iliac vessels and the ovary, it has to be a dilated fallopian tube, pyosalpinx, hydrosalpinx, unless proved, even ectopic pregnancy, unless proved otherwise. Now, fibroid uterus is again one pathology which needs to be, looked at, especially when a patient is coming with infertility, menorrhagia. We need to map the fibroid. This mapping is very essential because this particular patient, again, I may remove this particular fibroid, I will remove this fibroid, and I may leave this. I may not want to remove this. I may not want to remove this. But their patient may go from one center to the another center, and then they do the ultrasound, and they will think that, oh my God, the fibroids are still there. So doctor did not do a good job. The only thing which happened was I did not show this picture to the patient. I did not tell her that I am not going to remove these fibroids because they are very tiny. They are not going to bother you in infertility. And I don't want to give too many cuts on your uterus, making it weak. So this is again very important thing that we should keep in mind. Isthmocele is again an entity which is nowadays commonly seen patients coming with previous cesarean section, post-menstrual bleeding, spotting, foul-smelling discharge, infertility. And they are not able to pray because of this continuous spotting. Because what happens is whenever the patient in the patient who have isthmocele, at the time of previous C-section, there is this healing where it has occurred, but it has left a small pouch-like thing at the level of the isthmus. So that has even, see, whenever you're doing an ultrasound, suppose the patient has a previous history of C-section, I suggest look for isthmocele. So many times you will find that isthmocele is there, but she has no complaints, but your eyes will get tuned to looking at it, and then when patient really has a problem, you will pick it up instantly, and then you can manage it either hysteroscopically or laparoscopically, depending on this residual myometrium, whether she wants to conceive, and then we can you can go ahead for the surgical view. Again, in fertility management, we need to do a baseline ultrasound. Okay, so whenever we do a baseline ultrasound, it is important to see what is the antral follicle count of the patient. Now, these are the follicles which are now earlier we used to think that this is the ultimate physiology which is meant for human body. However, now we know that there are various waves which are coming during the cycle. What we have been noticing was only from day 2. Now we can even monitor these waves in the luteal phase. So those are little, I will not go into details. So these are the antral follicles which are formed. Out of these antral follicles, one follicle is selected to grow, and this follicle becomes dominant, and this is the follicle which ovulates. Now, when we are doing this monitoring, some important points here, that if we want to do an IUI and you want to add HMG to the patient, the right time to add HMG is when you already see a dominant follicle. If we add HMG over here, in this stage, if I add HMG, what will happen? All these follicles will grow, right? So here these follicles are on their way of disintegrating, and if I add HMG, this will act on this particular follicle. When this follicle is growing, it is secreting estrogen, and this estrogen is giving a negative feedback to the HPO axis, and that negative feedback is making all these follicles undergo atresia. However, this follicle is an intelligent follicle. It is secreting its own estrogen, its own FSH, and this follicle grows and becomes the dominant follicle. Also, if you want to add estrogen for thin endometrium, If we add estrogen here, it will cause a negative feedback and we will not get a dominant follicle. However, if I add estrogen here for a patient with thin endometrium, this follicle is already secreting its own FSH, or I may add HMG along with that. This follicle will keep on growing and the estrogen will not have a negative feedback on this particular follicle. When we look at the follicles, the follicle grows 1 to 2 millimeters per day. It can go to 18 to 20. Sometimes we see ovulation happening even at 20 to 23. So, and again, when we are doing ultrasound monitoring, LS surge. So suppose you are doing ultrasound monitoring and you find that there is a sonolucent halo, there is a cumulus here. You can see the cumulus here, and the good blood supply all over. What does that mean? That means it is a pre-ovulatory follicle. It might rupture, and you do the PSV is more than 25. So that means it is an impending rupture. What do I do next? If the patient is for IUI, I would perhaps do either her urine LH or I will do a serum LH for her. And if the LH is raised already, that means I should do her IUI today or tomorrow and not wait that I give the SCG today and do the IUI 36 hours later, because she would have already ruptured, because she is already pre-ovulatory, impending rupture, she can rupture anytime. Many patients say that my follicle does not rupture at the time of IUI. So 2-3 things we should keep in mind. One is that it is not a event, the rupture. It is a process. It is a slow process, and it may start not at 36 hours, sometimes even at 40 hours. So all of us have seen patients, we have given the trigger and she does not reach. गाड़ी पंक्चर हो गया, something happens and she reaches the clinic at 38 hours, 39 hours, and we have still found that the follicles have not ruptured. So it can happen. Repeat the ultrasound in the evening, and more often than not, you will find that the follicle has ruptured. This is how on day 23rd, you will see a secretory endometrium, and this is the corpus luteum here. And if I have this finding on day 21 of an infertile couple, at least I know one thing, that this patient probably is ovulating well. Then, of course, endometrium also needs to be evaluated. This is a grade A endometrium, grade B endometrium, grade C endometrium. And how is the blood flow to the endometrium? Zone 4, 3, 2, 1. Sometimes we find that patient ka endometrium was not so good, but she conceived. And we are very happy and we are jumping. So hold on for the jump, because these patients who conceive with thinner endometrium than expected, they have a very high risk of early pregnancy losses. So that has to be kept in mind, and we cross our fingers till she crosses 12 to 14 weeks of pregnancy. Sometimes we find a very large follicle early in the follicle, day 7 पे एक बड़ा 18 mm का follicle है. You are confused whether it is a follicle or it is, what is it? So this could be a selected follicle which did not become the dominant follicle. So you see for another follicle lying next to it, which may be 12 mm, and when you put the color Doppler, you will find that 12 mm follicle is better supplied with the and you follow that 12 mm. Ignore this. This is nuisance value. Sometimes it may be present even on day 2 of your next cycle if the patient does not conceive in this cycle. Sometimes we do have IT people who do the LH test at home and urine LH is positive, which is absolutely fine, and they follow that, don't conceive, come to us. Especially patients who have some kind of PID or endometriosis. The endometrium becomes secretory. The follicle does not rupture but slightly shrinks in size, but there is no free fluid in the pouch of Douglas. So the luteinization has happened, but there is no rupture of the follicle which has happened. So these are the patients where in the subsequent cycle we can suppress the endogenous LH. So on day 10, day 9 or day 10, when you see the follicle 14, 15 mm, that is the time you can give an antagonist along with an HMG for 1 or 2 days till you get a follicle of 18 mm, 18, 19 mm in size. Give the trigger with SCG and do the IUI 36 hours later. And of course, if the patient has endometriosis, these are the patients who do get benefited by a laparoscopic surgery with very good AMH, younger group of patients, mild to moderate endometriosis, and can go for the surgery, and then these patients can try with IUI. So how to measure the size of the follicle? Always in 2 diameters. You take one diameter like this, then in the center you take the second line, and all these modern machines will give you the average of the two, and that will tell you what is the size of the follicle. So three things when we are doing ultrasound in infertility: dominant follicle is there, but it is just atretic, it has nuisance value. Then a normal ovulatory dominant follicle you can see, and then whether it is a unruptured luteinizing follicle, that again we have to keep in mind. So we need to have a sound knowledge of ultrasound for all OBGYN. Suspect pelvic pathology, any troubleshooting, especially in infertility management, can really be managed if you're doing your own ultrasound. So thank you very much, and thank you everyone for the blessings for the VP for post West Zone Foxy election year 2024. So thank you very much, everyone, for the kind attention. Thank you so much.
Thanks, Dr. Meenu, for a very crisp talk. You touched the basics and yet covered all important aspects of infertility. I fully agree with you that all gynecologists should be doing their ultrasound. We can correlate better. We have seen the patient, we have then managed, and then you can go back to your ultrasound findings and correlate better. And one thing I just wanted to point out in endometrioma, I have recently encountered two cases. Like when we are having a look at endometrioma, always look for any abnormal nodule or any vascularity within the endometrioma. I have come across two patients. One had a small nodule. On MRI, they reported as teratoma, immature teratoma, I mean dermoid, and it turned out to be malignancy in an endometrioma. Another young patient who started with endometrioma, somehow when I did ultrasound, I was not very happy. There was a small shadow, and I monitored her CA, put her on Dianjust, and within 2 months, her CA 125 went up to 2000, and she also turned out to be malignancy. So, any mural nodule, if you see within an endometrioma, just be on guard. Both were less than 30 years of age, these patients.
Very good take home message, Induji, that yes, we need to keep in mind this possibility of malignancy in an endometriotic cyst. Yes.
Thank you very
Yes. Thank you, Dr. Meenu. Madam, you have really covered all the aspect on ultrasound, and it was really informative talk. And as I said earlier, wish you all the luck for your future endeavors, and we hope that we will also see success in all these endeavors. Thank you very much.
Thank you, Ashok sir. Thank you so much. Thank you.
Well done.
Thank you, ma'am. I think it was a great session, and I'm sure all our delegates must have benefited from all the small tips that you told us. So now let's move ahead with the next session, for which the speaker is going to be Dr. Neha Mishra. Welcome, ma'am. And I would like to invite our chairpersons for the next session, Dr. Kamna Datta and Dr. Nidhi Khera. I request Charu ma'am to introduce Dr. Kamna Datta.
Thank you so much, Madhura. So it was indeed a pleasure to interact with the AOGD, office bearers. And we have Dr. Kamna Datta, an MS-FICOG professor and the secretary of AOGD for the year 2024-25. Dr. Kamna, I'm sure you're going to be extremely busy this entire year, because the general secretary is the one who has to, bear the maximum brunt of all the events and all the functions. And I'm sure you're going to do it with great elan. Your area of interest is high-risk pregnancy and oncology, and you have multiple publications in national and international journals. Our second chairperson for this session is Dr. Nidhi. Can we have Madam's CV? Dr. Nidhi Khera is a Senior Director, OBGYN, and is the head of the High-Risk Pregnancy Unit at Max Hospital, New Delhi. She also has a special interest in high-risk pregnancy, fetal psychology, robotic surgery, adolescent health and PCOS, and gynec endoscopy. A diverse, interest basket looks like. And she has authored various chapters and articles for both national and international books and publications, has won numerous awards at national and international levels. We're extremely fortunate to have both of you here as our esteemed chairpersons today. So over to you, chairpersons, to introduce our next speaker.
Thank you, Dr. Charu, and thank you, organizers, for giving us this opportunity to come on this forum. And it was a pleasure talking to you, Dr. Charu, interacting with societies going beyond borders and reaching out to various other societies. Thank you. It's a very meaningful session we are going through, and as difficult it is to conceive for an infertile patient, it is another difficult task for a lady to go through pregnancy and through labor. So with this very pertinent and important topic we have for the next session, Dr. Nidhi, would you like to introduce our speaker, Dr. Neha?
Kamini, you can do it. Right.
Okay, thank you, ma'am. So Dr. Neha Mishra she's a very enthusiastic young gynecologist working at Atal Bihari Vajpayee Institute of Medical Sciences and RML Hospital. She is also the treasurer for AOGD 2024-25, and she has a lot of medals and publications to her credit. We now hand over the session to Dr. Neha to carry forward. Dr. Neha, please.
Thank you so much, ma'am, for such a kind introduction. I really feel humbled to share the screen with the eminent gynecologist and respected seniors. I'll be sharing my screen. So is my screen visible, ma'am?
Yeah, yes. Make it slideshow.
Yeah, I'm doing it. Okay. Slideshow. Okay. Is it okay? Should I start?
Yes. Yeah.
Thank you so much, organizers and respected seniors, for allowing me to speak on the topic so close to my heart, intrapartum monitoring for joyful motherhood. So we all know that intrapartum care revolves around two prongs, that is care of mother and intrapartum fetal monitoring. In this session, we'll be covering the care of mother very briefly with more focus on the intrapartum fetal monitoring. So the care of the mother, that should start in the antenatal period only, about the education about labor. Care should be executed throughout the labor in all stages, in one-to-one manner preferably. Communication should be effective and rationalized. Women should be offered position of her choice during labor and delivery, and she should be mobilized adequately. Hygiene precautions should be taken very in a proper manner. Pain relief should be offered to every pregnant woman during labor. Active management of third stage of labor should be given. Early identification of danger signs is a must. Respectful maternity care to be executed to maintain dignity, privacy, and confidentiality. And labor care guides should be followed in all laboring patients. Now coming to the need of the fetal monitoring in the labor. So we all know that fetal blood supply is temporarily interrupted during uterine contractions. In a healthy fetus, there is no alteration in heart rate. Whereas in fetus with borderline oxygen reserve, there is an onset of hypoxia. And intrapartum fetal monitoring is done to detect potential fetal decompensation, to allow timely and effective interventions to prevent perinatal or neonatal morbidity or mortality. This is usually done via intermittent auscultation, that is IA, or electronic fetal monitoring. There are other modalities as well, like fetal scalp stimulation, fetal scalp blood sampling, fetal scalp lactate. These are not done usually They are done in very special circumstances. And SOGC guidelines 2020, they don't recommend these modalities like fetal pulse oximetry, fetal echo, or STAN analysis. They say that they have no benefit. So we all are faced with the same question, whether it is intermittent auscultation or electronic fetal monitoring. Is electronic fetal monitoring better, or should it be done in every pregnancy? So let's find the answer. In 2017, a Cochrane review was published, including 13 trials, who compared 37,000 women, and they found that in women who were going electronic fetal monitoring, there was significant increase in LSCS and instrumental delivery. Coming to the fetal part, there was no difference in perinatal mortality. There was no difference in the cerebral palsy or any other benefit. Just the risk of the neonatal seizures were halved, but the long-term outcome was not affected. So how to do the intermittent auscultation? It should be done for preferably 1 full minute soon after the contractions, or it can be done in 2 other manner. That is, counting should be done for 2 intervals of 30 seconds and added. Counting can be done for 4 intervals of 15 seconds and then added together. It is usually done in low-risk patients from 37 to 41 weeks. Below 37 weeks and above 42 weeks, it is recommended to do electronic fetal monitoring. Accelerations and decelerations should be recorded along with palpation of maternal pulse hourly. So there are so many benefits of intermittent auscultation. They're cheap. Woman is less restrictive. She can move around. She can give birthing to her position of choice. But it comes with certain challenges, like it's very difficult to do in an obese woman, and it requires cooperation on the part of the woman as well. So SOGC practice guidelines recommends that in first stage latent phase, intermittent auscultation should be done hourly. In first stage active phase, that is beyond 5 centimeter, and second stage passive phase, where woman is not pushing, it should be done every 15 minutes. In second stage active phase, where woman is pushing actively, it should be done every 5 minutes, should be done every 5 minutes or following every contraction. Intermittent auscultation findings can be classified as normal when the contraction pattern is normal, baseline heart rate is between 110 to 160, and there's absence of decelerations. The accelerations may or may not be present. They don't change the pattern. The abnormal intermittent auscultation is categorized when there's tachysystole or abnormal baseline rate in terms of tachycardia, that is fetal heart rate more than 160, or bradycardia, that is fetal heart rate less than 110, or changing fetal heart rate baseline, presence of decelerations, and arrhythmia. So current evidence says that intermittent auscultation can be done safely in healthy term women devoid of any risk factors. In women who have opted for epidural analgesia, frequent intermittent auscultation should be done. That is, every 5 minutes for 30 minutes after the initiation of epidural and after bolus top-ups. For women who are having combined spinal epidural anesthesia for any cause, electronic fetal monitoring is the method of choice. Admission test is defined as cardiotocography of 20 to 30 minutes duration carried out immediately on admission to labor ward. It aims to screen candidates who are at increased risk of intrapartum hypoxia, to recognize pre-labor acidosis, and to identify fetuses requiring continuous electronic fetal monitoring. Coming to the evidence regarding admission CTG, we are presenting the ADGA trial, which involved 3,034 women. And this study demonstrated that there is no difference in obstetric or neonatal outcomes between intermittent auscultation and admission CTG for women with possible labor onset. Only problem with the admission CTG that they poses the pregnant woman at increased risk of continuous CTG. So even admission CTG is not recommended in women without any high risk factors. So current evidence doesn't recommend admission CTG for healthy women, and it has shown that women who have done admission CTG they're more likely to have minor obstetric interventions like epidural analgesia, continuous electronic fetal monitoring, fetal scalp blood sampling. It is recommended in high-risk pregnancy. Some of the indications of electronic fetal monitoring are maternal tachycardia, maternal pyrexia, suspected chorioamnionitis, significant meconium, fresh vaginal bleed, severe hypertension, gestational hypertension, delay in the progress of labor, hypertonus or tachysystole, and oxytocin augmentation. Non-significant meconium is not an indication for electronic fetal monitoring. Electronic fetal monitoring has a two-scale, horizontal scale that is called as paper speed also. It is usually 1, 2, or 3 centimeter. Most of us uses 1 centimeter per minute. And the vertical scale is 20 to 30 beats per minute per centimeter. As we can see in the figure also, the interval between the two red lines in this figure represents 1 minute. And fetal heart tracing is displayed in upper pane, and uterine activity is displayed in the lower pane. So coming to the intricacies of electronic fetal monitoring, we'll first learn about baseline heart rate. So it is the mean rate rounded to increments of 5 beats per minute during a 10-minute tracing segment. And there is at least a 2 minutes period where there should be a minimum interpretable baseline duration. We exclude episodic changes and the segments where the FHR is very variable, that is more than 25 beats per minute. And sympathetic system accelerates the fetal baseline fetal heart, whereas parasympathetic system or vagal nerve stimulation slows the baseline heart rate. So there's causes of maternal and fetal tachycardia. There are some maternal causes like fever, infection, dehydration, hypothyroidism, some drug intakes. For fetal causes are infection, prolonged fetal stimulation, hypoxemia, and abnormalities. Fetal bradycardia causes can also be categorized into maternal and fetal. The maternal causes are usually hypotension, position, some drugs, some connective tissue disorders like SLE, whereas fetal causes are umbilical cord occlusion, fetal acidosis, vagal stimulation, head compression, etc. Now, the baseline fluctuations in the baseline variability is fluctuations in the baseline that are irregular in amplitude and frequency, quantified as amplitude of peak to trough in beats per minute, regulated largely by autonomic nervous system. The ascending limb is denoted by the parasympathetic system, and the descending limb is represented by the parasympathetic system. So in this figure, we can see that my slide seems to be stuck. My slide seems to be stuck. So the baseline heart rate, we can see in the figure. So there is a variability marked. My screen doesn't move. Oops. Okay, it's moving. Thank you. Sorry. So we can see in the figure that there are lines drawn through highest and lowest point of the trace in any 1 minute segment, and they mark for the baseline variability. Okay, so baseline variability have two components, short-term and long-term. So short-term variability is beat-to-beat variability from 1 hour wave to the next, whereas long-term variability is demonstrated by oscillatory changes during 1 minute, and that results in waviness of baseline. So here are some figures which I'm sharing. So first figure is absent variability. Here we can see that there's no variability at all. The second figure denotes minimal variability, that is variability less than 5 beats per minute. This third figure demonstrates moderate variability, that is variability between 6 to 25 beats per minute. And the fourth figure represents marked variability, that is variability more than 25 beats per minute, which is pathological. So decreased variability, that is variability less than 5 beats per minute, reflects fetal compromise, that is acidemia. The causes are fetal sleep, prematurity, hypoxia. So what's a sinusoidal pattern? We all know that it's a sine wave-like pattern with amplitude of 5 to 15 beats per minute. In the sine wave-like pattern, there's long-term variability, but no or fixed short-term variability. And the sinusoidal waveform fluctuates above or below baseline with absence of accelerations. The causes are fetal anemia and tissue hypoxia. Coming to acceleration part, in a POG more than 32 weeks, we follow 15 into 15 rule, and in a POG less than 32 weeks, we follow 10 into 10 rules. So here, the time of the onset of the acceleration is abrupt. Acceleration lasts for more than equal to 15 seconds, with the peak beat is more than 15 beats per minute of the initial fetal heart. There should be more than 2 accelerations for a reactive, for a good CTG, and prolonged acceleration is more than 2 minutes, but less than 10 minutes. If accelerations last more than 10 minutes, it's a baseline change. So here in this graph, we can see 2-3 accelerations which are coming periodically. There are 15 beats per minute more than and lasting for more than 15 seconds. Now, early deceleration. Early declarations, first we should know, early declarations are not pathognomic. They are purely physiological changes due to vagal nerve activation due to head compression in the second stage of labor. Here, the acceleration, the nadir of the deceleration, the nadir of the deceleration coincides with the peak of the contraction. Coming to late decelerations, here, lag of greater than 20 seconds seen before the onset of the contraction and that of decelerations. And the onset of the late and early decelerations are gradual. They occur more than or equal to 30-second period. The causes are maternal hypotension, excessive uterine activity, and placental dysfunction. The variable declarations differ from early and late declaration in terms of they are abrupt in onset. There's abrupt decrease over a less than equal to 30-second period, and the decrease is more than 15 beats below baseline, which persists for 15 seconds but less than 2 minutes. There's a typical V-shaped pattern, and it results from umbilical cord occlusion. Then there are certain decelerations which are uncomplicated, which happens due to partial cord compression, due to baroreceptor reflexes. That is presence of shouldering along with variable dexels. This is purely physiological response to normal labor, and we don't require to do any action or anything as of now. But there are certain concerning points when they are accompanied with variable decelerations. They are if variable deceleration is persisting for more than 60 seconds. If the decrease in fetal heart rate is more than 60 beats or fetal heart rate actually reaching to 60 beats per minute, there is reduced baseline variability within that deceleration part. Failure to return to baseline, W-shaped trace, and the absence of shouldering. This is an abnormal feature of a CTV trace. Coming to prolonged decelerations. Prolonged decelerations are those decelerations, they last more than 30 minutes, but less than 10 minutes, and they represent uterine hyperactivity, cord entanglement, prolapse, hypotension, maternal seizure, fetal descent, abruption, Valsalva, etc. Oh, this is very interesting diagrams, which shows how to interpret decrease in FHR. First, we see that it shifts gradual in onset or abrupt in onset. If it is abrupt in onset and it persists for less than 15 seconds and its decrease is less than 15 beats per minute, it has variability. If that decrease lasts for more than 15 seconds and decrease is more than 15 beats per minute, it is variable deceleration. Then there are certain concerning points in variable decelerations which categorize the electronic fetal monitoring trace as uncomplicated and complicated. We've already learned what is complicated in terms of they last more than 60 seconds, the fetal heart rate falls to more than 60 beats per minute, and there's absence of shouldering, there's W pattern, etc. If the onset is gradual, that is more than equal to 30 seconds, then the decrease in FHR is early or late decelerations, depending on the coincidence of onset, nadir, and recovery with onset, peak, and end of the contraction. So this is a trace. This is a table showing how to classify the intrapartum electronic fetal monitoring tracings. We've already learned what is normal. So what are atypical? Atypical ones are those where the baseline is below 110 but above 100. If the baseline is below 100, that is abnormal. If the tachycardia, that is fetal tachycardia, persists for 30 to 80 minutes, that is atypical. But if it is persists for more than 80 minutes, is abnormal. Rising baseline is atypical, erratic baseline is abnormal. So variability, if it is less than 5 beats per minute for 40 to 80 minutes, it is atypical. But if it is less than 5 beats per minute for more than 80 minutes or greater than 25 beats per minute, that is marked variability for 10 minutes, along with presence of sinusoidal patterns, that is abnormal. Accelerations की presence और absence बिल्कुल determine नहीं करती कि हम intrapartum EFM tracings को कहाँ पे categorize करेंगे. They could either be present or they're absent. However, in abnormal tracing, they are usually absent. Coming to the Dexel's part, in a normal trace, there will be only early decelerations or some uncomplicated variable decelerations. Coming to the atypical trace, there might be uncomplicated repetitive trace variable decelerations, or there could be intermittent late decelerations. When these intermittent late decelerations become recurrent late decelerations, that is, they persist for more than 50% of the contractions time, the trace is classified as abnormal. So abnormal trace, we have to do urgent actions. For the atypical trace, we increase our monitoring part. And for the normal trace, we continue with the same line of management and labor is progressed. A little bit, few things about internal electronic monitoring. It is done via attaching bipolar spiral electrode directly to the fetal scalp. And fetal heart rate is derived from RR interval in this internal electronic monitoring. This is fetal scalp stimulation. This slide shows the fetal scalp stimulation. It is an indirect estimation of fetal acid-base balance. And if the fetal scalp stimulation results in acceleration, that means that fetal blood pH is more than 7.25. The predictive value of FHR acceleration after fetal scalp stimulation is good. But value of non-accelerative response is poor. Stimulation can be done either by some finger or forceps or some vibroacoustic devices. Digital fetal scalp stimulation is recommended in response to atypical electronic fetal heart tracings. And in absence of positive acceleratory response with digital fetal scalp stimulation, fetal scalp blood sampling is recommended. If fetal scalp sampling is not available, delivery should be prompted depending on the clinical judgment. Fetal scalp sampling has certain prerequisites that membrane should be ruptured and cervix should be dilated more than 3 centimeters. The current evidence says that fetal scalp blood sampling should be done in women with abnormal fetal heart tracings at gestations more than 34 weeks when delivery is not imminent. If digital fetal scalp stimulation does not result in an acceleratory fetal heart rate response and pH more than or equal to 7.25 and lactate less than 4.2 denotes a normal fetus. So coming to take-home messages, evidence-based guidelines must be followed for optimal perinatal outcomes. Clinical judgment of normal, atypical, and abnormal findings on electronic fetal monitoring by treating obstetrician is a must. Respectful maternity care and use of labor care guides should be done to enhance perinatal outcomes. So this ends my talk. Thank you so much for the patient listening.
Thank you, Neha, for a wonderful presentation. It has indeed explicitly covered all the basics as well as to the finer intricacies. You have very beautifully covered the interpretation and the finer nitty-gritties of CTG. And this is extremely important that we are able to spread it far and wide, because a proper understanding of the CTG and intrapartum monitoring is extremely important whenever we are dealing with an electronic fetal monitoring, because otherwise it leads to an unnecessary panic and increases your operative interventions. However, intermittent auscultation even today still remains the main modality that is available and feasible in the remote centers. So we should not let go of that, and we should also know how it's to be done. So labor and delivery is actually a physiological process. It's not a disease, and it should be the endeavor of each and every obstetrician to make it a happy and a moment of celebration for the mother. And at the same time, picking up wherever it is going wrong, it is not going as per where it should be going, and we should be able to intervene early. So the concept of respectful maternity care should actually be put more in practice rather than just theory, and we should get into the habit of a shared decision making and an effective communication. Thank you, Pune Society, and all my respected seniors and mentors. Since the topic of the webinar series is the cutting edge, there's only one thing that I would want to add for this intrapartum monitoring, Neha, that you've very beautifully covered, is also a need for an intrapartum ultrasound. Dr. Meenu has so beautifully taught us scans and imaging in gynae cases, but there is again a very large and unmet need of probably bringing this technology to intrapartum use also, where we are able to make a decision as to where your operative vaginal delivery would be successful, where you need to intervene early for a cesarean section, and which patients would have a successful outcome wherein you are getting stuck. So thank you, Neha. Thank you once again.
Thank you, Neha. Very wonderfully explained intrapartum CTG monitoring and interpretation of the CTG. It is very important for these sessions to be regularly held, especially at the postgraduate levels. I think the students it should be hammered into the head of the students that this is a very important aspect of taking care of a mother during the intrapartum period. Along with the CTG, when we are talking about intrapartum care, a joyful intrapartum care, it's also the care of the mother. We need to take into account her the simple things like her hydration status, her pulse rate, her blood pressure, the moral support a lady should get during labor. So all these things have to be cumulatively handled, and it should be given, the advice should be given to the residents in both practical as well as theoretical way to take care of the baby and the mother cumulatively. So wonderfully done, Neha. I think it is very important for every one of us, all practicing obstetricians, to learn to interpret the NST, because day in and out we are seeing the CTGs being done and cesareans being done for fetal distress. So learning to interpret the CTG is an art which takes time to come. And also it is important to get back to the cesareans we are doing for fetal distress. It's important to audit these files, and it's important to see the NSTs where the cesareans were done for fetal distress indication or for abnormal CTG. So these things will help us improve every way. Thank you, Neha, and thank you, Dr. Charu, organizers. I hope we could do justice to the session. Thank you.
It was indeed a very fantastic session, and Dr. Kamna, Dr. Neha Mishra has highlighted so beautifully on so many aspects of intrapartum care. And I think that along with the postgraduate students, sometimes we as consultants, we tend to forget a number of things that we learned during our postgraduate days. And so maybe that is the whole reason for this webinar, where we as private practitioners also need to, relearn all these things, because panic, especially when you sit in the lead obstetrician's role, panic can be a very bad driver. And so obstetrician's distress is sometimes more than the fetal distress, which can lead to C-sections. So thank you so much, Dr. Neha, for highlighting, all those various aspects of joyful motherhood. Thank you very much. And thank you, esteemed chairpersons, Dr. Nidhi Khera and Dr. Kamna Datta, for your valuable inputs regarding this particular talk.
Can I add one more thing here, Dr. Charu?
Yes,
so, when you're actually doing a cesarean for a fetal distress or any of those non-reassuring fetal heart rate patterns, those indications, it is extremely important to have a proper documentation and keep your NSTs attached in the file.
Yes,
now, a basic problem comes that whatever your NST print is and whatever the ink is, it will get faded over a period of time, and you will not be able to defend yourselves later on. So, I have also also learned it over the years. A small practical tip is you take a photocopy of that and you attach it in the file. Your ink from the main paper will fade off, but this will not fade off, and that will be a good evidence for you, God forbid, if something later on happens, because these records need to be preserved for a long time. So, wherever you do not have the option of having an electronic version of your files, this would be a practical tip.
Fantastic message, Dr. Nidhi, because this is indeed the truth. Barely, you see the file 2-3 months down the line also, they've all faded.
Yes. Yeah.
So that is really very good, very well said. So Dr. Madhura, over to you.
Yes, ma'am. Thank you so much, everyone. I think we had 2 excellent talks by our speakers. And with this, we come to the end of the webinar. So I request Charu ma'am again to give the word of thanks.
All right. Indeed, it is a great pleasure to be associated with AOGD. We have so many friends and we are keeping on making new friends as far as AOGD is concerned. And I always look at your organization as an extremely, I'm not saying it for the sake of saying, but I'm in 1 or 2 forums of yours, and the number of events that you people have is really mind-blowing. And, the number of drills you'll have, the kind of small plays you'll enact, so as to explain PPH or the protocols for PPH, or so many new things that keep going on with AOGD are really worth noticing and worth following. So it was really a pleasure today to do this particular webinar along with AOGD. So Pune Obstetric and Gynec Society is extremely happy to have done this particular webinar. Dr. Meenu, thank you so much for coming up with the idea of the cutting edge webinar. And we are so happy that for the last 4 months, we are doing it each and every week without a break with so many different societies. I am very grateful to Dr. Sunita Tandulwadkar, the chief guest of today's webinar, and our guests of honor, Dr. Neerja Bhatla, Dr. Niranjan Chavan, who spared their valuable time for this particular event and for blessing the webinar. We are also very grateful to Dr. Ashok Kumar. Just at one phone call, he told me, give us a little bit of breathing time. I'm just taking over as the president of AOGD, and then we'll surely be with you. And he was true to his word, and he gathered the most fantastic, faculty for this particular webinar. So we're very thankful to Dr. Ashok Kumar, Dr. Indu Chawla, Dr. Neha Mishra, Nidhi Khera, and Dr. Kamna Datta for having been a part of this beautiful webinar and made it so much more interesting academically. I thank BSV, Team BSV, Mr. Prasad Kulkarni for all the arrangements that he always makes. And of course, it is always a pleasure to be with Dr. Vaishali Chavan on the same screen, whether in person or virtually. So I also thank Dr. Aarti Nimkar and Dr. Meenakshi Deshpande and Dr. Amol Lunkad, who are the current office bearers of Pune Obstetric and Gynec Society, for having given us the opportunity to continue these webinars, although our term is now over. And of course, Dr. Madhura, who has to bear the brunt of all of us, because we just designed the program and then she has to execute it, which she always does so beautifully. Thank you, Dr. Madhura. Dr. Aarti, pleasure to have you here. As always, you all are both together. The team is working so hard that they must be in POGS office planning some further event. Madam, you are on mute.
Nobody recognizes.
How is that even possible? You all are soon going to become famous everywhere, because you all are going to be in each and every webinar, and you all are going to hold more so on your own also. So thank you. As I just said, thank you for giving us the permission to continue this particular webinars.
Okay, thank you, Charu.
Thank you. I think Dr. Meenu seems to be
at the last. Okay. I am leaving. Okay.
Thank you, Dr. Aarti. Thank you very much. So thank you, esteemed faculty, for your precious time, and goodbye till we meet each other once again. Thank you. Bye-bye.
Recording stopped.